Kia ora tātou. It's my pleasure to introduce the next session, which will be in two parts. Firstly, a group presentation of about 20 minutes, and then Rees Tapsell, he will conclude this overall session with a zone of about 20 minutes, including questions. The integrated network Kaupapa Māori Health and Addiction Service was developed in a partnership between the Whanganui District Health Board and the Māori Health Outcomes Advisory Group. The Māori Health Outcomes Advisory Group, established in 2008, formed a partnership between the District Health Board Planning and Funding Division and 5 iwi health provider organisations. The development of this group was in recognition and an extension of the governance partnership between Whanganui District Health Board and Hauora a Iwi, the Māori Relationship Board, at an operational level. The intent of the group is to work together to identify health strategies and service solutions that will reduce inequalities and improve the health for iwi communities and Māori living in the District Health Board area through strong and effective advice and support to the Whanganui District Health Board planning and decision-making processes, and collectively to increase the capacity and capability of iwi health providers to be responsive to the needs of Māori. Please welcome the integrated Kaupapa Māori Mental Health panel.
Tēnā rā koutou katoa, ngā mihi kia koutou, nau mai, haere mai. Welcome all. Just want to say to the conference committee, thank you very much for inviting us to present today. Quite daunting actually. Thank you for the introduction, mātua, ngā mihi kia koe. I just want to start with the mahi katoa working together and the boundaries that we cover. This is the Whanganui District Health Board area, Rohe, and from the east down to the southern and over to the west is basically the rural providers area. I just want to talk about Otaihape Māori Committee, that is a iwi provider within Taihape that covers the area right over to the Gentle Annie, if anybody knows that rohe, and down to Rata, the south, over to Rotorua in the west, and up to Hehetahi in the north, which is close to the Waiuru Desert Road. Some of the services that we provide, and I'm not going to read them out, you can see what those services are, but I just want to say that we do have a navigator, a winner position within our GP service. It is a new, and I just want to acknowledge the clinical manager from our GP Taipei Health Limited. It is a new service, and by golly, it is a great service that navigates and threads our whānau, and not only the whānau, but the GPs, into helping and assisting our whānau. So that's me. I will hand it over to Lydia.
Kia ora koutou, my name is, can you hear me? Kia ora koutou, my name is Lydia Martinga, and I'm the Service Manager for Te Kotuku Hauora Limited. The regional rohe we cover is Te Runanga o Ngātiapa's rohe, which is from the northern part of Mangaweka down to the southern region of Parawanui and Bulls, across to Fordale, Kaongaroa, Whangaehu, Chirakina, Ratanapa, and the Martin community. I have a team of 10. We're primarily health promotion and health services and social services. As you can see above, those are the contracts that we have that we provide to the whānau in those areas. We have one clinician, 2 social workers and community health workers. So kia ora.
Kia ora tata, I'm Grace Taiaroa. I'm the service manager for Hinengaro Hauora, which is the mental health and addiction service within Te Oranganui. Te Oranganui is the iwi health provider in Wanganui, which covers all of the area geographically you saw before. The services on the PowerPoint that you can see are purely our mental health services. We have a range of services in Te Oranganui, including our own GP practice, but within our mental health service, these are the different opportunities available to our whānau, of which we will talk in more detail later with my friends here.
Kia ora. I'm Pet McJanelle, and I'm the service manager for Te Puke Karanga Hauora. If there's anyone in the room that has visited the Wanganui National Park, you'll have an idea about the area that we actually cover. We travel from Raitahi, where our administration office is, and we have whānau in a small village called Pipariki. Down from there, 11 kilometres, another group of whānau in Jerusalem. And then we backtrack to Pipariki and have to get on a jet boat and go up to a marae called Tieki. That's 20 minutes upriver. That's the only access available. We have it's a mobile suitcase service. We're a very small team with a big location, an area that consumes a lot of driving. And our vehicles are 4-wheel drive. We have wet weather gear, gumboots, a collapsible shovel. The only thing we don't carry is a chainsaw, but everything else we do carry. So it kind of gives you a bit of an idea on the location and the area that we travel. Kia ora.
Oh, kia ora koutou katoa. My name is Bonnie Sue. I'm the manager at Ngāti Rangi Community Health Centre. Ngāti Rangi Community Health Centre is marae-based at Mangarongo Marae in Ohakuni. But we are a community health centre mandated by iwi. Our services, as you can see, are basically the same as some of the other providers, but from the second weekend in February, our whānau order contract and our Waimarino community health workers contracts have been combined under one new integrated whānau order service. And I'm not sure if Dr. Jim Corbett is present here today, but I just want to acknowledge him if he is, because his organisation has been very instrumental in helping us make this integrated service work. Talking about isolation, like PET, because we cover Ohakuni, Raitahi, Waiouru, up to but not including National Park, and also with this new contract, we now are expected to provide services around support for maternity to what is stated as the upper reaches of the Whanganui River. We're not quite sure what that actually means, because of course the upper reaches actually go right up to Taumaranui, but we're presuming it's going to be from PET just described to you, Tieki, which you have to access by jet boat, back down to Pipariki. So that's something that we're looking forward to in the future, and thank you for this opportunity to present. Kia ora. My turn? Okay. Basically, we were here today, we've just given you an overview of our services and what our services do. We're considered a little bit unique in that we're all members of MOHAG, M-H-O-A-G. And MOHAG is the acronym for Māori Health Outcomes Advisory Group. It's a Wanganui District Health Board initiative. And some of the things that we've been involved with under MOHAG, as well as providing advice to the District Health Board, has been the development of this kaupapa Māori mental health and addiction services. And as you'll see, in June 2008, the DHB reviewed the services and decided that, rightly, wrongly, or otherwise, but as a result of their review, they would disseminate the mental health services back out into the rural communities. And it's our success story that we're actually here to talk to you about today. As you can see, following the disestablishment of the mental health services from the hospital at the Whanganui District Health Board, the services came out to us as 4 rural iwi providers, with the clinicians' roles carried out by Hinengaro Hauora, that's Toiha, and Grace will speak to you more about that later.
Kia ora. Wanaungatanga. In terms of achieving pukumahi, and that's really about the providers working collaboratively with our funders. It's about our individuality. It's about ensuring that we kept our own mana intact. It was quite hard to start off with because there was a lot riding on what the final outcome would be. We worked really hard. We had noho, which meant that we spent many weekends away from home on marae and worked early hours of the morning, covering contracts, service specifications, timelines, what were the relationships going to look like, how was the clinical coverage going to be, and it was kind of all cards on the table, so there was a lot to get through. We came up with a generic model as far as a lot of our policies and procedures were concerned. We managed to, we had a shared vision using kaupapa Māori framework from entry to exit. The service was fully integrated with other mental health and addiction services, with the main objective was to provide a recovery-orientated community-based assessment, treatment and therapy service for mental health and addiction problems that is accessible, coordinated and effectively targeted for Māori. When we first started off, there was a lot of things riding on this. We really didn't know what our funders were expecting of us, so we became quite anxious. We were a little bit suspicious, but we managed to work through that whole process to come up with the model that we've got, and it's been hard, but we've worked hard, and we've been proud enough to, well, I'm proud enough to say on behalf of us that the Whanganui District Health Board have walked alongside of us right throughout the whole process. So that's made it a little bit easier for us. Kia ora.
I'm just going to talk a little bit in regards about relationships. In 2006, the manager of the Whanganui District Health Board's Manager of Population and Health and Inequalities invited us 5 Māori providers to form a group to its funding and planning arm, basically to advise on issues pertaining to Māori within its rohi. This was a brave and exciting move by the DHB, and hopefully they don't have any regrets, as we don't. We certainly don't. This group has grown from strength to strength. Not only has a strong relationship developed between Māori Health Outcomes Advisory Group and the Whanganui DHB, has strengthened that, but it's also within the group itself. And if anyone sitting in here know anything about iwi working with iwi, then you will sort of know why I'm making that statement. It can be quite hard sometimes. But I suppose through the shared vision and our mission, that our goal was for the betterment of the whānau that we serve, was why we're sitting here today, testament to what we're doing. So, who would have thought that the representation from 5iwi could achieve the results that you will hear and bear witness of what we've done today, and yet they did. And it was because of the shared vision and the kaupapa. And we know that the reason that we're here is to provide opportunities for our whānau and their whānau to improve their general well-being, to such an extent that they can self-manage and move freely within society. This will always be our goal, and we thank the District Health Board for the opportunity to do this by trusting us providers to deliver the kaupapa Māori mental health services to our whānau, which hopefully will be a model that will roll out into other areas. One thing I'd like to just say that hearing the kōrero this morning with Te Urero Flavel was in regards to building these relationships. I would like to actually put a challenge to this forum, is that we will work with anyone that can help us to help our whānau. Can you tell me how we can work better with the GP services to be able to do that better? Kia ora.
So thanks, Liddy, for that. Just recently we've undertaken an evaluation of the unique nature of this contract with the DHB, and some of the things that came out of that was the importance of partnerships. What we learnt, as you've heard with relationships, is that everybody had to be honest about what they wanted to get out of this, and what was the similar links for us all was our whānau. And because we'd all been autonomous in our own practices, and we all wanted to be the boss and in control of something, we had to let go of that and realise that if the whānau were in the centre of all that we planned, and they were the ones with the control, that nothing could go wrong. So when we changed our focus and put our whānau in the centre of all that we do, we've now seen the positives that could come from that, and our whānau direct our practice into the future. One of the things on here we've got is primed, so that came out of the evaluation was that the DHB could see from data that we're making a difference in our rural communities, because there's since been a reduction in access to specialist services at the hospital, as well as admissions into the acute inpatient service in Wanganui, which is Te Awhina. We are really lucky at present that the psychiatrist in Wanganui is very passionate about being able to support people to stay well in their communities. So we work really closely with them to help that happen for us. Although you could see the huge geographical area that we cover, like Pete said, they go down a river on a jet boat to see some of their whānau. We are 5 separate iwi with our own different tikanga, with our own kaupapa and values that we uphold, but we come together as iwi Māori with a commonality to help our whānau. It doesn't mean that we have to give up who we are, though. We're able to maintain that. One of the challenges that you haven't already heard about has been with the District Health Board, the Community Mental Health Services. So really it was around processes and establishing clinical pathways that would help the doctors that we work with feel safe, that we could appropriately support our whānau in the community. So a lot of work has gone on in the last 18 months to improve communication between all of our services and the Wanganui Hospital Service. For us as Te Oranganui, we're based in Wanganui, and we're the clinical hub, so the nurses function from our organisation and provide support to the iwi providers to do the day-to-day care of the whānau in the community. So Te Oranganui employs the nurses. Each of these iwi providers has a whānau ora kaimahi in their practice in their rural locations, and our nurses sit out in those rural locations with them. But because we're in the city, we have easy access now to the psychiatrists at the hospital, and the relationships require ongoing maintenance and effort from us all. But I'm proud to say that we have a really positive functional relationship with our community health, mental health service in Wanganui. There's a range of improvements that we will continue to work on that the evaluation identified, which included the hospital has Māori health workers already in the mental health service, and so they're currently reviewing their own Māori health plan, and we'll see what the place for them in the future will look like and how they can work better for us. I guess what's key in terms of the future for us being here is to say that we want to be able to work with our whānau in environments that are supportive to them. We want to help them to maintain their wellness so they're not having to end up in the hospital. And in the past year, of all of our services, we've had 6 people access the acute inpatient service in the past year. Only 6. That was something happening probably in the past on a monthly basis. So it shows us that we're doing something good for our whānau at home. The key probably is how, like Lydia said, how can we work better with GPs so that we can help our whānau who are with GPs in the way that we provide care. So if we're visiting on a weekly basis and they're with the GP for something else, if you know that we're involved, we're going to be encouraging our whānau to communicate that with the GPs, that we can share information so we can feed back to you if we're home visiting and noticing any concerns. Although most of our whānau are with a psychiatrist and we have daily access to them, we attend the community mental health MDTs, we're a part of that. A few of them are starting to be managed in their community by their GPs now, and the psychiatrists at the hospital are improving their relationships with the GPs so that they can support them to do that. So I guess for us it's about how can we communicate better with you to help overall meet the needs of the whānau. Kia ora tātou.
Kia ora koutou, ngā mihi kia koutou katoa. Well, I'm breathless after that. What a wide-ranging area that they have to cover, and are doing it with such enthusiasm and with such energy, and I noticed with few men. Well done. Questions?
Hi. I was just wondering, without like our district nurses, they go and see patients and they write on a laptop and then it comes back and it downloads into the whole practices information. Do you guys do that? Like with sharing information, how do you sort of share it?
Oh, sorry. In our own practices, with our own GPs, our nurses can input the data into medtech, but they're only with our clients who have shared GPs with our service. In the hospital, the Whanganui Hospital has allowed our nurses access to their JADE system, so we write notes into JADE and the psychiatrist or any other health professional at the hospital can see that, but they're only with our shared clients. We can't go in and look at just anybody's notes. Push the button. No, yeah.
Button, right, sorry, I can't see. Newfangled ideas, I don't know. Sorry. And in the rural areas, the way we report is we report to the ministry, directly to the ministry, and through Primed. Primed is how the other 4 providers report. So as far as the shed, information, that's where it goes to.
Can I just add too, I'm not sure whether we made this quite clear, the service provision that we provide for kaupapa Māori mental health and addictions is in the high to acute area. It's not low or medium. So the district health nurses, for example, would really not have occasion to be reading any of these client notes in all probability. But obviously, if there was some reason to be engaging with them, that would be a different story, but it would probably therefore be verbal. But it is the higher classification for mental health. It's not the lower and the medium. Just wanted to clarify that. Kia ora.
Can I also just say that just before us we're the IT people, and it's it's quite frustrating that you have Primed and you have Jade and you have medtech, and the iwi providers have Aura admin.
So, you know, the softwares don't actually connect together, and there is, you know, there is that, that gap, that enormous gap in terms of IT relationships. So hopefully they can do something about that, and we can actually start talking together in terms of, you know, our IT systems. Kia ora.
Kia ora, ko Ron James Aho from Rural GP from Wairau. Thank you very much for an interesting presentation. You were asking about how to connect with general practice. You obviously have the Maori Outcomes Advisor Group for the DHB. Have you approached the PHO to establish the same type of relationship?
Yes, we have. We actually do have a really good relationship with our WRPHO. The WRPHO is the primary health organisation within Aotearoa at the moment. And we also are part of the National Coalition PHO, so which Toiha are a part of, Te o Ranganui. So yeah, we do have a good relationship with them.
Can I just follow on from that to say that the GPs in the areas we're based in, the relationships are great. We need to develop better communication with the GPs who we have clients registered with who are all over town, in town. Rurally, the relationships are better. We have Dr. Benakin Martin, for example, if he knows that he has a client with Te Kotuku who's currently on antibiotics, he'll ask the key worker at Te Kotuku to check when they visit that they're still taking the antibiotics and report back to him. It's a phone call, but you know, it's extra wraparound support. So that's happening in the rurals well. It's not happening so good in town.
Time for a final question. Yes, down the front here.
Hi, it's Leslie Barclay speaking from Australia, and I just want to pay tribute to you. I am absolutely blown away with what you're doing. I think it's marvellous. It's absolutely at the cutting edge. We need to learn from you. I'm just hoping that someone writes up your lessons and publishes it, because not everybody's going to have an opportunity to come and sit and listen to what you're doing. But you're at the cutting edge of what we need to be doing around rural health. And the Maori leadership is absolutely wonderful, and our Australian Aboriginal people would have, you know, wonderfully listened and learned from what you're demonstrating. So please write it up so we can all share it.
Thanks so much, and on that uplifting note, may I ask you to give your appreciation to this outstanding presentation for the wonderful work they do amongst our people. No mind having it. And before they go, I'd just like to make a presentation. Thank you. And Jeremy, I think is it afternoon tea? Oh, no, sorry. We've got one more speaker before we have a break. Sorry. No, it's my pleasure to continue on with this session to introduce our next speaker. He also will speak for about 20 minutes, and we're just running a little bit late, but it's my pleasure to introduce to you Rees Tapsell. Rees was brought up here, born and brought up in Rotorua. He graduated from Otago University in 1988. He's asked me not to go through all his bio notes, and I think for save him embarrassment, but it's absolutely fantastic, and he wishes to speak to you in terms of the work that he's been doing in terms of his professional and research interest in the epidemiology of mental disorders, Māori mental health, service development outcome measures in mental health, offenders, and undergraduate and postgraduate education and training. Rees is married, lives in Auckland with his wife and 3 teenage boys. Rees Tapsell.
Kia ora, Bill. Ko tēnei he mihi nunui ki a koe te kaiwhakahare o tō tātou nei hui. Kei kone nā reira ki a koe, tēnā koe. Me kia koutou ngā wahine toa. Ko nei whaia mai i Taranaki Maunga, ko tēnei he mihi nunui ki a koutou. Mō koutou mahi hoki mō o mātou tūroro Māori. Nā reira ki a koutou, tēnā rā tātou. Me kia koutou, tēnā rā tātou. As Bill said, my name's Rees Tapsell. Can I first of all thank the panel, or in particular Ross Lawrenson, at least I think I want to thank Ross Lawrenson, for inviting me along to talk. I do feel a little bit like he gave me a bit of a hospital pass, though. One, because he wasn't all that clear about what it is that he wanted me to talk about. And two, because quite clearly I currently stand between you and afternoon tea. And that's not a good place to be. So I am going to try and whip through things reasonably quickly. Bill did say that he wanted me to try and take somewhat of a clinical focus, hoping that that might be something that you might be interested in. You'll see, however, from my title slide, that I make no claim to be an expert in the area of primary mental health. I have, however, for my sins, worked as a GP for a couple of years before I realised that general practice was, if not wholly, certainly significantly about managing psychological and psychiatric problems. So I figured I'd go on and get a bit of specialty expertise in that area. So this is not going to be a funny talk, but we do actually have somebody who works in our DHB that has quite a quirky sense of humour. And actually, as it happens, the first talk that I wrote for this was going to be a bit kind of management speaky, including words like stakeholders. And because of that, I thought that you might appreciate that slide. In fact, what I'm going to talk about is that I'm going to talk briefly about the epidemiology of what we know about mental health disorder in the community. I'm going to make a couple of comments about the changing world, and I think that previous speakers have really focused significantly, particularly in the area of IT, on the changing world and some of the opportunities that the change in our world brings. I'm going to just, I guess, identify, I think, a couple of cautions around our changing world. Then I'm going to talk briefly about some common clinical scenarios, and as I talk about those scenarios, I don't mean to be telling my grandmother, not incidentally that any of you look like my grandmother, but my grandmother to suck eggs. I do appreciate that all of you have a lot of experience in the management of these disorders, but if you'd allow me, I might just make a couple of observations as a psychiatrist around some of those things, and then talk about what I consider to be some of the traps for young players. And they're not just traps for young players in rural general practice, they're traps for young players in any aspect of the assessment and the management of people with psychological or psychiatric disorder. Let's whip very quickly through the epidemiology, because I'm just assuming that you know a little bit about this. You will know that your own fraternity have done quite a lot of good work in this area in terms of looking at general practice cohorts, or cohorts of people that come to general practice, and you'll see that the mental health and addictions problems, looking at a cohort from general practice, pretty common. We are very lucky. We, in 2006, undertook a large community-based epidemiological project looking at mental health problems in our community. And as a result, we have quite a lot of information about the prevalence, the severity, and the help-seeking behaviour of those people with those disorders. 39.5% life prevalence of a mental disorder. Even if you look at the instrument, you look at the methodology, and you say this is highly American, and what do we know from asking people, structured questions anyway, 39.5%, that is a big percentage of people by anybody's description. 20% in the last year, and 11-oddish% in the last month. So we're talking about a really common set of problems. And again, you, as I, when I did general practice, I think that will resonate for you. In terms of severity, so we're not talking about all of these mild or disorders that don't actually impair people. These are disorders that are actually quite severe, many of them, and cause significant disability. Notwithstanding that, though, actually what we also know, notwithstanding that disability, is that there still are a number of people that don't get access to a health practitioner being either in the primary, secondary, tertiary healthcare sector. We know from that study that there is a significant association with a range of socio-economic correlates to youth particularly, and with poverty. So again, I think those are important things for you to remember as you see young people coming in your front door, as you see people who have the challenges that poverty brings. And I would also make the point that although not statistically significant, the amount of the burden that Māori patients, Māori people in the community carry in terms of these disorders is high, and their help-seeking behaviour suggests that actually they don't get any help from anybody. So again, be mindful when young Māori who have the struggles of poverty come in your front door, you should be thinking foremost about the issues of their psychological and their psychiatric well-being. And I'm going to come to some of these clinical situations in a bit, but what we know is that the most common problems are anxiety disorders, mood disorders, and substance misuse disorders. That they are most common, as I said, in the younger age group, that anxiety and mood disorders are most common in women, that mood disorders cause really the most significant interference with life. And again, you'll all know the number of sickness benefits that you will have had to have written out around mood disorder, mood problems, associated alcohol and drug problems. I imagine that that resonates for you. Suicidality, a very significant issue for all of us, but again, in particular, I suspect for you. And I know that you will be having another talk tomorrow, I think, and I suspect on Wednesday, I think it was, that you've already had somebody from the Federated Farmers talk to you. You know, we all know about the rates of depression, that peak of the rates of depression in older men, and in particular in the farming fraternity. So for those farmers that consult you, for those farmers' wives who consult you with concerns about, very general concerns about their husbands or their partners or their families, again, low threshold for just delving a little bit more deeply into what might be going on there. The changing world. I mean, you know, we're all mindful of the global financial crisis, and money's tight. That affects all of us. That affects the population, that affects those of us as providers, both in terms of putting limitations on the ability of people to access our service, but also actually, of course, in a perverse sort of a way, causing people stresses and anxieties and problems in their lives. And of course, that's an international issue, but there are right now much more significant local issues like the drought. I heard today, I think it is, that we have now established the whole of the North Island as being in drought status. So there are some real worries for a number of, I think, the people that are out there in rural settings. One of the things that, and I freely appreciate that this might reflect my own experience with my university-age kids, but one of the other things that I think has been a kind of a change with this changing world is the level of expectation that many of the patients that come to us with. They come, many of them having been on the internet and knowing, you know, that all sorts of different ways in which people have looked at the problem that they believe they have, and they have a set of expectations of us, of the ways in which we will respond to those problems. And my sense is that that has actually become increasingly the case. And of course there are good things about that, in that we'd hope that our patients are better informed, but there are sometimes bad things about that, in that somebody comes in, they're a little bit worried about the fight that they had with their husband or their wife, and they expect that you'll put them on an antidepressant. So there are some challenges around that, I think, that some of them are good, some of them are not so good. And so too the immediacy of response. Everything seems, you know, there's this expectation that everything will happen yesterday, if not yesterday, you know, 5 minutes ago. Everybody expects that things will get better quickly. In the area of mental health, as in the area, I think, of many chronic conditions, that is not the case. That is just not the case. Time actually is a very important part of what we prescribe for people with psychological and psychiatric problems. And as I said, there's this issue of information and misinformation, people coming in believing a whole set of things that really have absolutely no scientific base whatsoever in terms of the effectiveness or the efficacy of a particular intervention. So I thought now that I'd talk a little bit about some common scenarios, and I'm going to whip through these because if you want to talk to me about it in any more detail, I'm happy to do that afterwards, or I can hang around for a little bit. But I wanted to talk briefly about mild to moderate depression, what we call this mild to moderate depression. And what I think we've realised really over the last 10, if not 15 years, prior to that we had this kind of idea that depression was this thing that came, we gave people an antidepressant, it went away and everything was, we were all well again and we got on with our lives. In fact, actually what we know is for many of those people who do become quite depressed requiring antidepressant treatment, and or one of the talking therapies, that it oftentimes isn't an easy or quick fix, that actually there is a chronicity around this disorder and a significant morbidity and of course, as you know, a mortality, notwithstanding the best of treatments, the best of interventions. Having said that, it does require at the front end, I think, when I say the front end, whoever sees the patient first, to undertake a comprehensive assessment. Now, when I say that, I know you'll all be sitting out there saying, yeah, he works in DHB land, he gets an hour and a half to do it, we get 15 minutes. Totally appreciate that that is a challenge for you, but just making the point that it is actually quite important to do a proper assessment around someone's depression at the front end, so that there's some baseline around which, when the first antidepressant doesn't work and or the cognitive behavioural therapy, if in fact somebody has an ability to access that, is kind of struggling a bit, so that we can go back and review that and think about the diagnosis and was this person really depressed or was there something else going on that might help us to understand why it is that these therapies, these interventions are not as successful as we thought that they might or should be. Standardised instruments. How many of you use any form of standardised instrument in any aspect of your practice, not just mental health, in any aspect of your practice? Yeah, so a significant number. I mean, I think there are a number of relatively easily used structured instruments, particularly around depression, that I would really and a number of them are self-rated, that actually have quite a lot of validity and reliability around them. I would strongly suggest that you consider using them, even if it's that you get your practice nurse to get the person to fill it out before they ever get in front of you. I think it's a useful way of just actually giving you some support in terms of that assessment, particularly if you don't have a long time to do it. Because it's very important to get some sense in your mind and around individual patients what constitutes a case. And please forgive me, I don't mean to be talking about people as cases, but I think you understand what I mean by caseness. Does this person actually have a bout of depression? Or is what we're talking about here just the extension of the rigours of life? Because those of you that follow, and if you do follow it, I feel sorry for you, but for those of you that might follow some of the evolution of diagnosis and classification in mental illness, particularly coming out of the United States, you'll know that there's this increasingly big push to begin to pathologise all sorts of things that actually I, and certainly my mother and father's generation, just called some of the difficulties of the stresses, the difficulties of life. Very important to be clear when you're talking with patients about whether you do believe that this is the case or not, because that is important down the track, as I said, when you begin to review your treatments, when you begin to think about, am I going to change the antidepressant, am I going to withdraw the antidepressant, am I going to increase the paroxetine to 60 milligrams, knowing that there are all sorts of consequences that come with that. Incidentally, my use of that brand in no way was endorsing that brand. That was just the first one that came into my mind. And having some kind of logical algorithm. Now, I know that standardisation is not always a good thing, but actually having a standard against which, we can kind of gauge variation of our practice is an important thing, is a good thing. And I know that a number of your PHOs might have algorithms like the map of medicine and the like. I think they are things that are very usefully used in terms of giving you some kind of guidance around a treatment algorithm. And I've made the point there, best practice, CBT and or antidepressants, mild to moderate depression, I'm sure you all know that if you were to cut it down to the basics, accepting that, we do all that we can do around the kind of social aspects of people's lives, with culturally appropriate interventions and other sorts of social interventions. In fact, if you're really serious about treating somebody's depression, the gold standard is the combination of cognitive behavioural therapy and an antidepressant. And actually, you know, whilst the drug companies would have you believe that this one's better than that one or that one's better than that one, any SRI is going to, you know, is going to do the business. I do appreciate also that in your setting and in many community settings, cognitive behavioural therapy is not easy to come by. I do understand that, but I'm just telling you that that is the gold standard. Also important as we kind of go through the process of treatment to actually look at so someone comes in, you start them on an antidepressant, for example, you refer them for some counselling or some CBT or something like that, to actually in your mind have a sense of what your therapeutic trial is going to be clear that you've given someone long enough and on a reasonable amount of antidepressant to be clear that they didn't respond. Because you know, one of the things that you often see in a secondary care setting is that someone will come in and they've had a bit of this and they've had a bit of that and they've had a bit of this something else, and it's kind of chopped and it's changed. And if you look back at it, it's often chopped and changed really because the patient themselves has been a bit upset and distressed about what's happening for them. But it makes it very difficult, you know, down the track. The more that happens, the harder it is to actually look back at that kind of therapeutic process, that therapeutic trial, to determine what, if anything, was actually successful. And so oftentimes what I found myself doing now when people come to me, and you know, I often do end up seeing people after a few trials, is stopping everything. And I would encourage you to do that too if you are at all equivocal about someone's response. Just actually take the opportunity to stop everything and have another look. Reassess. The other thing is documentation. Helpful down the track for somebody that might actually be referred on for a secondary assessment, for a secondary opinion, for the documentation around what happened through that therapeutic trial to come with them. And I guess I just make the point that if you don't keep good notes at the time, I suspect it's sometimes often hard for you to remember that, hard to include that in the referral letter that might come along. Making the point that, you know, with depression there is a significant mortality of around about 10%, and that's even given the best of interventions. How many of you incidentally have had patients that have suicided? Yeah, so a reasonable number. And it's never an easy thing, particularly if your patients are close to you, particularly if the patients you thought were doing really, really well, and then you find out that they suicided. You know, it's a tough thing to deal with. The other thing that I'd say is just, you know your level of confidence. And again, I don't mean to be telling my grandmother to suck eggs, but I think sometimes it is important to know when it's time to pull out rather than just trying a bit of something else. Time to pull out, time to get an opinion, a view from someone else, even if it's just over the telephone. So anxiety. I'm not going to talk about anxiety in huge detail other than to say that in New Zealand, as compared to other places like Australia, anxiety is still by most of us understood to be this thing that we all get a little bit of and we should just get over it. Actually, anxiety is not like that, or it is like that for most of us, but actually for a significant number of us, and statistics would say for a significant number of those of us in the room, anxiety is a major and crippling problem. So I would urge you to do a little bit of a reading around anxiety, because actually even in a secondary care setting, our psychiatrists don't assess anxiety disorders well, and they don't treat them well. So I think there is useful for you to just have some sense of the different disorders and the different sorts of approaches that you might have to each of those disorders. And it might be something that, you know, if you're in peer review groups, if your PHOs, might be something that you wish to have a little bit more of a look at in that format. So, you know, every secondary care practitioner says avoid benzodiazepines. I appreciate that actually benzodiazepines are very, very useful in an acute setting in some patients. So I'm not saying don't use them. I'm just saying be aware that, particularly in the problem of a person who has an anxiety disorder, it just makes the management of that disorder that much more difficult down the track if what they've had is the relief of benzodiazepines along the way. And the other thing is that there's a reasonable amount of research coming out of England and various other places that actually one of the biggest risks in terms of the mortality in depression is actually the associated anxiety that many people who get depressed have, and that actually anxiety is the big trigger factor, and people's sense of not being able to tolerate the levels of anxiety that they feel that are the things that actually drive oftentimes suicidal behaviour. So again, just being aware of that. Very briefly, psychosis, and particularly with the early presentations, you'll all have seen mum bringing in the young boy, or particularly the young boy actually, in their kind of teens, acting a bit strangely, gone off a bit, not sleeping during the day, watching TV all day, looking a bit weird, speaking to themselves. Again, the issue of assessment, very important to assess that. Oftentimes, if nothing else, to be clear that, because oftentimes, we'll want to believe that that's because he's smoking a bit of DAC. He's smoking a bit of DAC and he's fallen out with the wrong crowd. And sometimes that's the case, most of us that have got or had teenage kids know that they cycle through crowds. But important to be clear that that is or isn't the case, and not necessarily take mum or dad's view for that. And that just does require a little bit of an examination of, if he was taking drugs, when was that? What's the association with the kind of evolution or the onset of these symptoms? What's the relationship? I know that you will, all of you, much more than we in an urban setting, have quite a strong sense of the NGO supports that are around you, the people that you can actually engage and get involved, not only, as the last presenters talked to you about, not only in terms of presenting, those young patients, but also actually in supporting and advising and educating the families of people with early onset psychosis. It is actually one of the tragic disorders. For any of you that have got someone who's suffering a psychosis in your family, you'll know that it is a disorder that does not just irreversibly affect the life of that person, but irreversibly affect the life of everybody else around that person, their family and everybody else. And sometimes the best intervention that we can make is actually in making sure that all the supports are there for the family. And early referral. And again, I appreciate that that might mean that you have to refer people on into an urban setting, but I would strongly suggest that that's what you encourage, notwithstanding the fact that families might want to keep young kids at home. And of course, that is very important in terms of maintaining support, but it is also very important to get those young kids into some kind of process of treatment. And I say treatment in the widest possible sense, not just drug treatment, but all of the other kinds of interventions as well. Alcohol and drugs, I'm not going to talk much about that other than to say that it's an incredibly prevalent problem in New Zealand. The only things that I would say is just methamphetamine. How many of you are in areas where there's meth around? Yeah. Methamphetamine is a scourge. It is a serious scourge of a drug. It is, in a lay sense, what I describe as, and please forgive my language, but I describe it as madogenic. It's one of the few drugs that will cause any one of you, if given enough of it, to become psychotic. And so if you have any kind of preponderance whatsoever to develop a psychotic disorder, beautiful formula for developing an illness. Second part of methamphetamine that I think we should be concerned about is that it is also incredibly, incredibly disinhibiting. So what you have is the combination on one hand of someone that's becoming increasingly paranoid about everybody around them and incredibly disinhibited. That's a recipe for disaster. And you'll have read about how that plays out in the papers all around the nation. Again, be clear about dependence syndromes and know how to manage them. You know, as I know, that in particular alcohol, a number of them are life-threatening. The issue of insight and motivation, we talk a lot about insight and motivation, and I think they are really, really important concepts in the area of alcohol and substance misuse if people are going to do anything in the long term. But what I can also say with reasonable surety is that actually sometimes people's circumstances need to change in order for them to gain some sense of realising what's going on and what's happening for them. And again, knowing about treatment providers. I'm not going to talk about that slide other than to make the point that many people with chronic and enduring mental illness have significant medical problems. We continue to prescribe these things that I call the PEENs, the olanzapine, the clozapine, the PEENs, and you will know that the PEENs are cause significant and quite crippling metabolic side effects. And so to the extent that anyone that's on a PEEN in your practice can actually attract a bit of special attention from you in terms of both monitoring and managing some of those metabolic side effects, I would really encourage you to do that. So the last slide, how am I doing for time? Bill, how am I doing for time? You people are starving and want to get out there and get into your cup of tea, or can I finish this slide? I'll give you the last one. So the traps for young players, yeah, look, personality and its disorders. You know, you'll all have those tricky patients in your practice that you just wish would decide they didn't like you and go and see your partner. In the context of the assessment of these disorders, is really important for you to get some sense of the extent to which personality is a factor in the presentation. You know, there are a number of personality disorders, of course, where one of the kind of constituent parts of the disorder is dysthymia. So if you're getting someone coming in who has a dysthymic personality, you know, nice to be aware of that, be clear of that, to know that before you barge head on into an algorithm that involves the treatment of depression and then only for yourself to become depressed 6 months down the track that they're not actually responding. Personality is important. The old let's just try a bit of this, you know, it's easy to do in psychiatry and mental health. I understand that, you know, there's not a hell of a lot that's concrete in our specialty. But just encourage you, and I'm sure that most of you don't, but encourage you not to kind of out of a sense of a therapeutic, you know, a loss of hope to just say, well, let's try a bit of that or a bit of that or a bit of the next thing. I think if you're getting to that point, that's time to get a second opinion, even if, you know, second opinion from one of your colleagues, some sort of second opinion. Reassessment and being prepared to actually rethink your formulation, rethink your diagnosis, rethink your formulation is absolutely critical. In a secondary care setting, there's a hell of a lot of evidence to show that actually in the absence of that, you know, there are a number of highly qualified, very competent people treating people for a disorder that they never had. Important to reassess, important to be prepared to rethink your formulation. Important for you to be aware of the vulnerable persons legislation. Do you understand what I mean when I say that in the Crimes Act? Okay. So very briefly, there was an amendment to the Crimes Act that essentially it was around children in the first instance, but actually there is the incorporation of this concept of the vulnerable person and the need, the expectation that if you become aware that somebody is vulnerable in terms of being at risk to violence, being at risk, that there's the expectation that you will do something about that. The do something about that is not hell of a clear, but do something about that. And we can talk a little bit about that if you want later, but we probably don't have time right now. Transference and countertransference, do any of you know what those terms mean? No. Okay, I mean, they're incredibly important terms in the kind of area of mental health and in the area of dealing with people with personality problems. And actually, although we codify them, we make them these magical terms, in fact, actually, you know, they're the things that you and I do and live with every day with every new person that we meet. With every new person that we meet, there's a whole lot of stuff that happened to us way back when, even if way back when is an hour ago, that we take into that interaction that may or may not taint that interaction, but of course that is exactly the same thing for the patient. And it's useful sometimes to be clear about that, to just try and step back from an interaction and be clear about how much of this is actually about me, how much of this is actually about the patient, before you begin to think how much of this might actually be about the disorder. So that's transference and countertransference. And then the last one really is, you know, mental health is my partner's specialty. You know, I know that there are a number of practices where one partner in the practice, you know, almost by default becomes the kind of specialist in the area of mental health, largely because nobody else wants to do it. I think the trap in that is what I said before, and I go back to the epidemiology, which is that actually one partner in any practice, for those of you that are working in practices, cannot manage it all. Cannot manage it all, first thing. Second thing, it's hard work. It's actually hard work. So it's not, I think, sustainable for one person, and particularly with the kind of limitations of resources that you have in a rural setting, for one person to have to take that whole burden of people with psychological and psychiatric problems. So I think that is a trap for young players. So that's me.
Thank you very much, and we have time for one or two questions before we depart. Are there any questions, please?
I don't have to take questions, incidentally. I understand that afternoon tea might be much more important. Excellent. Afternoon tea.
I'm sure you'll be able to catch up, Rees, over